Good morning, students. Welcome to today's lecture. This is the final part of the topic disorders of bone. For the learning outcomes, at the end of this lecture, we'll be able to categorize bone disorders and give 3 examples for each. We'll be able to explain the etiology of dry socket. We'll be able to identify and illustrate the histopathology of osteoma and osteosarcoma. The remaining learning outcomes we have covered in the previous topic. So to refresh with the various categories of bone disorders, these can be basically categorized as fibro-osseous lesions, inherited and developmental disorders of bone, inflammatory diseases of bone, metabolic and endocrine disorders of bone, Paget's disease of bone, central giant cell granuloma, exostosis, and tumors of the bone. In today's lecture, we'll be discussing the inherited and developmental disorders, inflammatory diseases, exostosis, and tumors of bone. So first, let us begin with the inflammatory diseases of bone. The first topic is dry socket. This is a pathology which we would encounter in our dental practice. It is an unpredictable complication which occurs during the healing process of the extraction socket. The incidence of dry socket is around 1 to 3% of all extractions. Dry socket is also known as alveolar osteitis. Various risk factors are known associated with this pathology. These include a difficult extraction, smoking, and lower molars. It should be remembered that dry socket occurs commonly in association with the extraction of an impacted third molar. As you can see in this image, it shows the clinical features of dry socket. This lesion generally develops within 2 to 3 days of extraction. It is associated with severe pain. The pain is radiating in nature and often radiates to the ear. The socket is filled with foul tasting and smelling decomposed food debris, which, when it is washed away, reveals the denuded bone. Patients with dry socket generally present with halitosis as well. As you can see in this image, you can see that the decomposed debris has been found in the extraction socket. You can see an area of denuded bone as well. The pathogenesis of dry socket can be basically summarized under 2 headings. Dry socket includes a localized inflammation of the alveolar bone. This can be either following a failure of blood clot formation within the socket or due to premature loss or disintegration of the clot. As you must be aware, formation of the blood clot is an important step in the healing process of the extraction socket. Whenever this blood clot is compromised, it results in dry socket. So, the failure of blood clot may be because of relatively poor blood supply to the bone. Such instances are generally seen in elder individuals who would be suffering from osteopetrosis, Paget's disease of bone, or in individuals who have undergone radiotherapy. Such lesions involve generally relatively poor supply. So this would result in a failure of clot formation within the socket. Also, in cases where excessive use of vasoconstrictors have been performed, due to the prolonged vasoconstriction, the formation of blood clot may be compromised, predisposing to dry socket. In cases where an adequate blood clot forms, it may be washed away. Most common example for this is excessive mouth rinsing by the patient following tooth extraction. The patient may feel that the socket needs to be kept clean. However, the importance of blood clot is significant for the healing process, as we just discussed. So the patient should be advised not to rinse the mouth excessively. Or the blood clot may disintegrate prematurely due to fibrinolysis of the clot. If there is a separating infection within the socket, the proteolytic bacteria results in fibrinolysis of the clot, which would ultimately lead to dry socket. No specific bacteria has been implicated in this infection. Mixed type of bacteria are generally found. The socket will have food debris, saliva and bacteria, and the adjacent bone may become infected and necrotic. So, to summarize, following extraction, if it was a difficult extraction so as to result in trauma to the alveolar bone, or following extraction there is a separated infection in the socket, this would basically release tissue activators such as plasminogen, which would further be converted into plasmin, which results in dissolution of the clot, resulting in dry socket. So, in dry socket, there will be a piece of non-vital bone, which is generally separated by the process of bone resorption, which is caused by osteoclasts. The piece of non-vital bone is referred to as sequestra. It should be remembered that healing in a dry socket is extremely slow and generally follows the ingrowth of granulation tissue from the surrounding vital bone. To prevent occurrence of dry socket, identification of risk factors is important. This can be done by taking an opposite case history and undertaking a thorough clinical examination. Dry socket can be prevented by treating any infection, improving overall oral hygiene, providing smoking cessation advice. It should be kept in mind that during extraction, trauma should be minimized. Also, the patient should be advised to avoid excessive rinsing during the post-extraction period. Written advice sheets mentioning the above preventive actions can be useful. However, if dry socket occurs in spite of all the preventive actions, it has to be identified by clinical examination or by taking a radiograph. Radiograph of the extraction socket should be done to exclude any possibility of retained fragments or presence of foreign material. The affected socket should then be gently irrigated with warm saline. Any debris should be dislodged and aspirated. Once the socket is clean, it should be lightly packed with a dressing that contains an obtundant. This is done for providing pain relief and a non-irritant antiseptic, which further inhibits the bacterial and fungal growth within the socket. Appropriate analgesics should be prescribed. The patient should be kept under review until they are pain-free and the socket healing is ensured. It should be noted that sometimes the healing of the socket in cases of this lesion would be prolonged to as long as 30 to 40 days. So, keeping the patient under review and cleaning and irrigating the socket is advised. Moving further to the next lesion, that is focal sclerosing osteitis. This lesion is also referred to as condensing osteitis. Focal sclerosing osteitis generally involves osteosclerosis, which is due to a low-grade periapical inflammation, which is generally chronic in nature. The typical location for condensing osteitis is the periapical region of the tooth, most commonly occurring in relation to the permanent molar. As you can see in this radiograph, a well-defined radio-opaque lesion can be seen in relation to the periapical area of this premolar. This is what we refer to as focal sclerosing osteitis or condensing osteitis. The most important feature of this lesion is that these are asymptomatic and are identified incidentally while investigating some other lesion. Histologically, this lesion would show a localized increase in the number and thickness of bony trabeculae. The bone which is formed is of normal quality. A few scattered lymphocytes and plasma cells may be seen in the surrounding scanty fibrous tissue. Since there is more bone formation, the marrow may become less in amount. It should be remembered that it is probably because of a low-grade chronic periapical inflammation. Hence, for the treatment, the associated tooth needs to be treated by performing endodontic therapy or extraction, but for the focal sclerosing osteitis as such, no treatment is required. Moving on to the next important topic, that is osteomyelitis. The term osteomyelitis has been derived from the Greek word osteon meaning bone, myelo meaning marrow, and itis meaning inflammation. So, osteomyelitis is basically inflammation of the medullary portion of the bone. However, this inflammation is rarely confined to the endosteum, and it usually progresses to affect the cortical bone and the periosteum. Osteomyelitis generally occurs as a result of odontogenic infection which has not been controlled, or it may occur because of other infection. Most common example is infection which occurs in a traumatic event. Following a trauma, if the wound is not cleaned, it may be suppurated by an infection which can lead to osteomyelitis. Osteomyelitis reflects a balance between the nature, severity of the irritant, the host defenses, local and systemic predisposing factors. Basically, 3 predisposing factors can be given for osteomyelitis. These include the presence of any systemic disease which would result in a lowering of the host defense. Conditions such as diabetes or any other lesion resulting in immunocompromised state may predispose to osteomyelitis. Osteomyelitis is also predisposed in patients who are tobacco smokers and consume alcohol. In such patients, the healing may be compromised or the vascularity may be compromised. The third predisposing factors include conditions which alter the vascularity of bone. Pathologies such as osteosclerosis, Page's disease of bone, or radiation involving the bone will generally affect the vascularity, which would predispose to osteomyelitis. The pathogenesis of osteomyelitis basically involves a compromised vascular supply. It should be remembered that even though it may be because of an infectious etiology, the pathology of this lesion includes a compromised vascular supply to the bone. In case of an infection, there is basically which has reached the marrow of the bone, there is an acute inflammatory reaction. This would result in edema and formation of pus within the bone. When the edema increases, it results in increased intramedullary pressure, such that there is compression of the vascular channels within the bone marrow. This increased intramedullary pressure will result in vascular collapse, involving stasis of blood flow, thrombosis, and ischemia of bone. Such events would result in compromised blood supply, such that the bone does not receive nutrients from the blood, resulting in an avascular environment. This will lead to the death of the cells of the bone, that is osteocytes and osteoblasts, resulting in a dead bone, which is also referred to as sequester formation. Alternatively, the pus, which is formed within the medullary portion of the bone, along with the microorganisms, may travel through the Haversian system and progress peripherally towards the outer surface. Once this pus extends into the outer surface, it is collected below the periosteum, which is an unyielding piece of connective tissue. The periosteum is elevated and the vascular supply in the periosteal layer is disrupted, such that it results in a compromised vascular supply, following which there is avascularity of bone and sequester formation. To summarize, it should be remembered that the avascularity of bone is the primary reason for osteomyelitis. On the basis of clinical picture, radiology and etiology, osteomyelitis can be broadly categorized into two categories: suppurative osteomyelitis and non-suppurative osteomyelitis. Suppurative osteomyelitis is generally because of a infectious pathology or etiology resulting in pus formation. Non-suppurative osteomyelitis is because of a non-infectious pathology. However, there is a compromised vascularity. Suppurative osteomyelitis can be further classified into acute suppurative osteomyelitis, chronic suppurative osteomyelitis, and infantile osteomyelitis. Non-suppurative osteomyelitis, on the other hand, can be further classified into diffuse sclerosing osteomyelitis, focal sclerosing osteomyelitis, proliferative periosteitis, Osteoradionecrosis. Acute suppurative osteomyelitis is a lesion which generally occurs within 1 month duration. Signs and symptoms of acute inflammation are seen in this case of osteomyelitis. These include fever, leukocytosis, enlarged lymph nodes, and swelling of the affected area. The overlying skin in the affected area may be warm. This is because of the presence of inflammatory process in the area. Radiographs taken for cases of acute suppurative osteomyelitis do not show any changes. However, within 10 to 14 days, these may show some ill-defined radiolucency. There may be certain locations showing periosteal new bone formation as a response to the bone resorption. This can be appreciated as a single-layered radio-opaque line, which is due to the subperiosteal spread of the infection. When the infection involves the nerve, this may result in paresthesia of the lower lip. Drainage of exfoliation or exfoliation of fragments of necrotic bone can also be seen through the sinus tracts. This necrotic bone, that is sequestrae, may sometimes be surrounded by a vital bone formation, which is referred to as involucrum. The opening through which the pus escapes are referred to as cloaca. this point, I want to remind that cases of osteomyelitis is more common in the mandible as compared to the maxilla. This is because of the blood supply involving the mandible is from a single main vascular channel. However, maxilla on the other hand has numerous collateral source of blood supply. Hence, in the event that a vascularity is compromised, the collateral blood supply would result in continued perfusion of the bone. However, in case of mandible, a single blood may be compromised so that the bone does not receive nutrients from other vascular channels. So it should be remembered that mandible is more commonly predisposed to osteomyelitis as compared to the maxilla. Chronic suppurative osteomyelitis occurs over 30 days of infection. It may follow after an acute osteomyelitis that has not resolved, or it may be present primarily as a chronic osteomyelitis which has been a low-grade infection and has persisted over 1 month. Cases of osteomyelitis will generally present as a swelling of the jaw. There will be associated pain. Sinus formation will be there, through which there will be purulent discharge, sequestrum formation. The inflammation and infection may result in bone loss, resulting in loss of tooth or pathologic fracture. Patients may experience acute exacerbations as well during the chronic phase of osteomyelitis. Radiographic examination, as we discussed before, during the early stages, that is 10 to 14 days, the radiograph may not reveal any significant feature. However, following 14 days, there may be bone resorption, producing irregular moth-eaten areas of radiolucency. These are features of acute osteomyelitis. However, in the chronic stage, the bone loss would progress further, leaving behind patchy, ragged, ill-defined radiolucencies, which would be surrounding a central radio-opaque bone, which is representing the sequestra. Incisional biopsy performed for the case of osteomyelitis will reveal predominantly necrotic bone. Necrotic bone is generally identified by the absence of osteocytes within lacunae. As you can see in this photomicrograph, all the osteocytes are absent in the lacunae of the bone. The periphery of the bone will also be devoid of osteoblasts. We can appreciate some bacterial colonization and inflammatory cells in the connective tissue. A low power image will show a number of scattered sequestra throughout the biopsy tissue. The necrotic debris will contain polymorphonuclear neutrophils in case of acute osteomyelitis and lymphocytes and plasma cells in case of chronic osteomyelitis. So, the histological feature for both acute and chronic osteomyelitis will be the same. The only point of delineation is the presence of acute inflammatory cells and the clinico-pathological correlation. It should be remembered that a case of acute osteomyelitis would be less than 30 days in duration. Treatment for osteomyelitis generally involves surgical intervention such that the piece of necrotic bone has been surgically excised. This is complemented by antibiotics which would lower the infection. Small lesions are generally curettaged, or a process called saucerization is done, wherein the piece of necrotic bone is gradually removed by a process called saucerization. In case of extensive osteomyelitis, decortication saucerization is combined with transplantation of cancellous bone chips. Another alternative technique which has been involved includes the hyperbaric oxygen therapy. The oxygenation process improves the vitality of the bone. Moving further, chronic sclerosing osteomyelitis. It is less common and presents as either focal or diffuse. We have already discussed the focal form, which is also known as condensing osteitis. These are generally a proliferative reaction of bone to low-grade infection, commonly seen in older individuals in the edentulous areas. Presents as diffuse patchy sclerosis of bone, showing a cotton wool appearance. Clinically, the patient may reveal asymmetry as a result of swelling. Garre's osteomyelitis is an example of non-suppurative osteomyelitis. It is also referred to as periosteitis ossificans. This lesion involves focal gross thickening of the periosteum, which is secondarily a reactive bone formation in the periphery due to mild irritation and infection. Garre's osteomyelitis commonly occurs in young individuals who are below 25 years of age. In long bones, it affects the anterior surface of tibia more frequently. Within the jaws, mandible is the most common site, specifically the premolar area. The patient will show a bony hard swelling of the mandible which has been present for several weeks. This swelling may be associated with toothache or pain in the jaw. Occlusal radiographs are generally the best radiographic technique to identify Garre's osteomyelitis, wherein a focal overgrowth of bone can be seen on the outer surface of the cortex, which will appear smooth and well calcified. As you can see in this occlusal radiograph, a rim of dense radioopacity is seen on the lingual cortex, which is probably because of a low-grade infection from the surrounding region. The lesion as such does not require any surgical intervention. However, root canal treatment or extraction of the nearby carious tooth may be required. Moving on to the next form of non-suppurative osteomyelitis, which is also referred to as Osteoradionecrosis. This is a form of osteomyelitis which occurs in patients who have undergone radiotherapy. It should be remembered that radiation has the potential to reduce the vascularity of bone. This is due to proliferation of the intima of the blood vessels which supply the bone, such that it results in end arteritis. The vascular supply to the bone, especially the mandible, is compromised, resulting in the sequestration or formation of non-vital bone. It should be remembered that the region here is sterile. Patients are usually asymptomatic but are very susceptible to trauma because of the reduced bone density, and such traumatic events may also be superseded by infection. If the mucosa is breached, infection may spread rapidly, resulting in extensive osteomyelitis and painful necrosis of bone. Overall, this is referred to as Osteoradionecrosis. Another variant of sterile necrosis of bone is referred to as medication-related osteonecrosis of jaw. Previously, this lesion was known as bisphosphonate-related osteonecrosis of jaw or chemonecrosis. This is basically a case of osteonecrosis of the jaw secondary to a medication. Bisphosphonate is the most commonly associated medication. Osteonecrosis of the jaw may also occur secondary to certain anti-cancer drugs. Moving on further from inflammatory lesions, we will discuss about the genetic disorders affecting the bone of the jaws. Various genetic disorders are there associated with the jaws. We should be able to identify this. The table here shows a list of such genetic disorders. We need to be aware of the main features associated with this and the most significant clinical feature along with any possible oral manifestations. It is advised that students remember these three main points for the genetic disorders affecting bone. So we'll begin with the first genetic disorder, that is osteogenesis imperfecta. This lesion is known with other synonyms such as brittle bones, fragilities ostium, etc. Osteogenesis imperfecta is a hereditary autosomal dominant disease which bears superficial relatedness to dentinogenesis imperfecta. This lesion is because of mutations in the genes coding for pro-alpha-1 and pro-alpha-2 chains. This gene basically is associated with the formation of type 1 collagen. Type 1 collagen is an important component of bone and many other connective tissue. So, a genetic mutation involving this gene would result in improper or immature collagen 1 formation, resulting in various disorders, osteogenesis imperfecta being one of them. This pathology can be further classified into 4 types: type 1, type 2, type 3 and type 4. The bone quality in osteogenesis imperfecta is extremely poor, such that it results in porosity or fragility predisposing to fracture of bone. The bone fracture heals readily, however the new bone is also of imperfect quality. A characteristic feature of osteogenesis imperfecta is the presence of the pale blue sclera. This is because of the defective collagen which is also seen in the sclera. The defect of ear ossicles may result in osteosclerosis, resulting in deafness. Abnormalities of tooth may also be seen in osteogenesis imperfecta, which are similar to dentinogenesis imperfecta. There will be increased movement of the ligaments. The skull shape may be affected. Oral manifestations in case of osteogenesis imperfecta will include first dentinogenesis imperfecta. Apart from that, we may see class 3 malocclusions, anterior-posterior cross bites and open bites, impactions and ectopically formed teeth. Radiographic features will generally show bone with poor quality. There is osteopenia, that is, the density of the bone is reduced. In case of long bones, there is bowing or angulation of the long bones. The bones are susceptible to multiple fractures. Vermian bones can be seen in the skull. So as we had discussed, osteogenesis imperfecta can be classified into 4 types, that is type 1, type 2, type 3 and type 4. Each subtypes have their particular clinical features. Most of the clinical features are common. What is important for us to remember is with certain types, dentinogenesis imperfecta is associated. So we have to remember these types where dentinogenesis imperfecta are associated along with osteogenesis imperfecta. The next genetic lesion involving the bone is Marfan syndrome. This lesion results in multiple skeletal deformities. There is arachnodactyly, that is elongated fingers. Other skeletal deformities may be seen involving the face, such that the shape of the skull and face is narrow. The most characteristic feature of this pathology is that the joints are hyperextensible, such that it leads to frequent habitual dislocations. The range of mobility of the patient will be enhanced. The patient will be able to easily move the bones or joints to extreme variation or extreme extensions. Oral manifestations of Marfan syndrome include high arched palate, bifid uvula, multiple odontogenic cysts of maxilla and mandible may be seen. There may be temporomandibular dysarthrosis. The image here shows a high and narrow arched palate. The depth of the central portion of the palate is extensive. Cleidocranial dysplasia is another genetic bone deformity which includes abnormalities of the skull, teeth, jaws and shoulder girdle. The most significant defect is involving the shoulder girdle, such that there is complete absence of clavicles or partial absence may be seen. The characteristic feature is that because of this absence of clavicles, the patient will be able to approximate the two shoulders towards the midline. Oral manifestations for this case also include high narrow arched palate. Patients may show cleft palate formation. The maxilla is generally underdeveloped, showing large mandibles. Underdeveloped midfacial bones such as the lacrimal zygomatic bones. There may be prolonged retention of deciduous teeth. Cellular cementum is usually absent. As you can see here, there are various anomalies seen in relation to cleidocranial dysplasia. Osteopetrosis is a lesion of bone wherein there is increased bone formation. The bone turnover is generally affected. Osteopetrosis is also known as marble bone disease, Albert-Schonberg disease, osteosclerosis, fragilitis generalizata. It is a rare hereditary bone disorder. The pathogenesis of this lesion involves failure of osteoclastic bone resorption, such that the balance between apposition and resorption is disturbed, resulting in increased bone mass. Even though the thickness of bone is increased, it has poor mechanical properties. Osteopetrosis has been shown to show three forms, that includes the infantile, adult onset and intermediate. Infantile osteopetrosis is also known as malignant osteopetrosis. The bone lesions here are extensive. The patients fail to survive because of extensive growth retardation. Dentition may be delayed. Cranial nerve may be trapped, resulting in neuropathies. There may be osteomyelitis. The bones are extremely fragile. The pathology also results in bone marrow failure, which will result in pancytopenia. All these additional conditions together makes it difficult for the patients to survive. Generally, patients with infantile osteopetrosis would not survive for more than 3 to 4 years. Adult osteopetrosis, on the other hand, is also known as benign osteopetrosis. The extent of the lesion is quite low, and hence sometimes the lesion may be diagnosed incidentally. Such patients are predisposed to osteomyelitis. As we had discussed previously in the pathogenesis, osteopetrosis may result in compromised vascular supply, which may predispose to osteomyelitis. There may be entrapment of cranial nerves resulting in neuropathies and bone pains. We have also discussed that in osteopetrosis the quality of bone is compromised, which results in frequent bone fractures. Oral manifestation of osteomyelitis, osteopetrosis, will show medullary spaces which are markedly reduced. The increased bone formation would decrease the space for marrow tissue, which would predispose to osteomyelitis. Fractures of jaws may be seen, especially during tooth extraction. The teeth may show various defects, including enamel hypoplasia, microscopic dentinal defects, arrested root development, and dental caries. The tooth may also be impacted and fail to erupt into its normal position. Moving further onto the term exostosis. Exostosis is a clinical term generally reserved to describe a bony outgrowth. We have to remember that exostosis is a clinical term and not based on histopathology. Exostosis can be used to signify any form of bony outgrowth. These outgrowths may be developmental or reactive. Sometimes the neoplastic forms may also be clinically identified as an exostosis. The developmental forms generally are also referred to as torus. So torus is a form of exostosis that occurs at a characteristic site, either in the midline, wherein it is referred to as torus palatinus, or on the lingual surface of mandible, wherein it is referred to as mandibular tori. Tori are rarely seen in childhood and show a slow growth. They may vary considerably in size and shape, ranging from flat and small elevations to large nodular outgrowths. Reactive exostosis, on the other hand, may result from repeated trauma or irritation to the periosteum. Moving on to the tumors of the bone. Osteoma is a benign, slow-growing neoplasm consisting of well-differentiated mature bone. The osteoma generally presents as a hard, bony swelling on the surface of bone, and it shows on histopathology well-differentiated bone, that is of normal quality. Osteoma may arise as a central lesion, that is involving within the bone, or a peripheral region existing on the surface. Osteomas frequently are seen in relation to the paranasal sinuses. Majority of osteomas are diagnosed in the adult life. A bone biopsy performed for osteoma will generally show compact bone as seen in this photomicrograph, or immature cancellous bone, which would slowly mineralize further to become compact. It should be remembered that there is a syndrome known as Gardner's syndrome, wherein multiple jaw osteomas are seen within the oral cavity. So, identifying this lesion becomes important. Solitary lesions may not be associated with Gardner syndrome, but careful examination is required. Lesions such as tori should be kept in mind during this evaluation. Osteosarcoma is a common malignant bone tumor however rare in the jaws. Osteosarcoma, like other connective tissue malignancies, are commonly seen in children and adolescents. That is, osteosarcoma is common in the first and second decades of life. In older individuals, however, osteosarcoma may follow as a complication of Paget's disease of bone, or it may arise from some other pathologies. Clinically, osteosarcoma presents as a rapid swelling of the jawbone. This swelling is generally associated with tooth pain, or paresthesia. This is because of the compression of the nerves by the malignant cells. The spread of the lesion within the bone generally results in ill-defined radiolucencies, that is, the resorption of the bone will also result in mobility of teeth. So an unexplained mobility may be indicative of a malignant process. When assessing mobility, periodontal causes should be ruled out first before considering a possibility of a malignancy. Radiographs may reveal radiolucent to radioopaque or mixed lesions. Cases of osteosarcoma generally shows widening of the periodontal ligament space. When a biopsy is performed, it will show few characteristic features. The most characteristic feature of osteosarcoma is the formation of tumor osteoid. Osteoid is nothing but unmineralized bone. In case of osteosarcoma, there is extreme proliferation of osteoblasts. These osteoblasts are atypical in nature. That means they show dysplastic features. It can be seen that the proliferation of osteoblasts results in excessive number of osteoblasts such that they are present as sheets. These osteoblasts will secrete the bony matrix haphazardly throughout the tissue. This bony matrix is referred to as osteoid, specifically referred to as tumor osteoid. The bony matrix may undergo calcification in certain areas, resulting in formation of disorganized bone. The darker eosinophilic areas here significant mineralization, whereas the lighter areas, eosinophilic areas, signifies the tumor osteoid. Also note the sheets of osteoblast present in the background. So these three features are key to identifying a case of osteosarcoma. Once the diagnosis is established, treatment would generally require wide surgical excision along with chemotherapy. If the lymph nodes are involved, neck dissection is also done. So with this, we conclude the topic disorders of bone. I hope I have discussed all the important topics pertaining to this topic. For further discussion, please post your doubts or comments on the discussion board that has been created on Google Classroom. A link for this lecture will also be provided in the discussion board. With this, I would like to remind you that we are in the recovery mode of MCO. I request all of you to stay safe. Try to stay at home and avoid going out for unnecessary reasons. Make the most of the time at hand and prepare well for the exams. With this, I would like to conclude my lecture for today. Thank you for your patient listening.